Okay, so this is part 2 of endocrine where we are going to focus on diabetes mellitus. So to get started, a little bit of background, some terms that may or may not come up, but metabolism is this thing we hear about, metabolism, increasing your metabolic rate. Metabolism involves both anabolism and catabolism. Anabolism is the building up, and catabolism is the breaking down. So we're going to kind of refer to that in a roundabout way when we talk about, building up fats or breaking down proteins to get amino acids that then you can use to build glucose from those. So we'll kind of talk about it as we go along, but other than that, they're just terms. So molecules provided to cells to make ATP, so that's one of these things that we have to have. We have to have energy. So we make ATP, and we're able to get it primarily. The preferred source of making ATP is glucose. Okay, so we can use it. We can use fats when glucose reserves are lower. We'll use fat, and I have here fatty acids. So if you think of adipose tissue, the big jellyfish-looking thing with triglycerides, and triglycerides have this, this little glycerol. That's why they're called triglycerides. And then they have 3 fatty acid chains. Okay, so these fatty acid chains can be broken apart, and then they can be harvested for energy as well. Usually, what you end up making from those is something called ketones, and those can be used as energy as well. So proteins, amino acids, they can be used as energy, but that's not a preferred source. That's like a last resort that the body uses. It says, okay, we don't have any other energy, so we'll start using proteins, which means you're going to break down muscle tissue in some cases. You're going to break apart proteins because then those amino acids can actually be rearranged to make glucose. So that's not a preferred way for your body to do it, but it is possible. So supply and storage of nutrients is controlled primarily by the liver. So we're going to be talking a lot about the liver and the things that the liver is doing, and that's kind of a theme for the whole course. But the liver stores, processes, and mobilizes a range of nutrients. So these triglycerides we were talking about, cholesterol, which really isn't an energy source, cholesterol isn't, but it is produced in the liver, and then that cholesterol can be moved around to where it's needed. Amino acids, so you can break down proteins, or you can produce actually de nova, whatever, amino acids in the liver as well. So a couple of hormones, insulin and glucagon, we're going to talk about those. Cortisol, thyroid hormones. So thyroid is something I always fail to mention, but those can also increase blood glucose along with epinephrine. Adrenaline can cause an increase. Growth hormone can increase glucose. So it's not just glucagon that increases your blood glucose level. It's all of these other things as well. And so sometimes those things can all come at you and really increase glucose levels to an unsafe level. Okay, so this slide, epinephrine, growth hormone, glucocorticohormones. When we talk about that, we're talking mainly about cortisol, but these can also increase glucose levels. So epinephrine maintains glucose levels during stress, glycogenolysis in the liver. Remember, glycogen is this chain of glucose molecules. It's a storage form. Okay, so you just sort of put all these together in a big long chain, and then when you need glucose, you can just go through and whack these off one by one and then release that glucose, and then it can move into the bloodstream. Okay? And then it can be available somewhere else like muscle tissue or whatever. But that's glycogenolysis. Lysis means you're cutting. So you're breaking off those glucose molecules one by one and then releasing them, okay, to increase glucose levels. So epinephrine can do that. Inhibits insulin by beta cell secretion by beta cells. So epinephrine will decrease insulin, which is insulin wants to lower it, so that's going to keep it high. And it also has a lipolytic effect, which means that it can cause the breakdown of fat. So growth hormone is another one, increases protein synthesis, mobilizes fatty acids, antagonizes effects of insulin, just like we just saw that epinephrine does. And then the glucocorticoid hormones, uh, and mainly what we're talking about there is cortisol, although others kind of fall into that category. Glucocorticoid is just a category, but the gluco means that it causes an increase in glucose. Okay, so stimulates gluconeogenesis in liver. That means that you're forming you're generating new glucose. Okay, so that's what gluconeogenesis is. All right, so processing and storage of glucose, like I mentioned, glycogen, this is the picture I was trying to draw. Glycogen is a storage form. All of this little cool looking leafy snowflake looking thing is just a bunch of glucose molecules all strung together, okay? And then we can break those off when they're needed to increase glucose. So when glycogen stores are full, okay, so we've stored all the glucose we can as glycogen, then we start to make triglycerides. We'll start producing fatty acids. We'll stick them to that glycerol molecule, and then we have fats, okay, or triglycerides. Okay, and those can be stored in, well, they can be stored in a lot of places, even in the liver, but we usually think of adipose tissue or fat tissues where those are stored. So when glucose levels are depleted, we have gluconeogenesis, which I just mentioned, the production of new glucose from other molecules such as amino acids, glycerol, or fatty acids. Okay, so we can make brand new glucose. That's kind of cool, and that happens primarily in the liver. Utilization of fatty acids or amino acids as energy. So when fatty acids, glycerol, and amino acids are catabolized to make ATP, okay, so when they're broken down to make ATP, then they form acidic ketones. Okay. Why am I pausing on that? Because ketoacidosis is common with when these mechanisms kind of get out of whack, and then that can happen with low insulin, high glucose in someone with type 1 diabetes primarily. Okay, so acidosis means the blood pH falls and becomes more acidic. So what's going on? The pancreas, we're focusing here on the pancreas. I know we just went through a bunch of hormones that were related to the hypothalamus and the pituitary. Well, this one is pretty much regulated by the pancreas. There is some oversight, on the brain level, but primarily this is a pretty natural feedback mechanism. When the pancreas releases the hormones glucagon or insulin directly into the bloodstream. So when glucose levels are high, or there's an indication that they're going to become high, then what happens is that the pancreas, there are beta cells in the pancreas that will release insulin. Okay. Now the opposite is true when blood glucose levels are low. So when we don't have enough glucose, then we will, from something called alpha cells, we release glucagon. And glucagon will then trigger certain mechanisms that we'll talk about that increase glucose. So it's a negative feedback, both of these system that's directly for the most part relies on or is monitoring glucose levels. Okay, now I have here 99% of the pancreas function is exocrine, which means that really most of what the pancreas is doing is it's producing digestive hormones. Okay, but there is this little function, this 1% function that it's also controlling. I think it's safe to say that glucose levels. So beta cells release insulin when they detect high blood glucose levels or when triggered by the gut-derived hormone released by the stomach after eating. So you've eaten something, it's going to trigger the release of insulin because just about anything you can eat will have glucose in it. And it's going to have energy. So alpha cells release glucagon when they detect low blood glucose levels, such as between meals. So this is how we kind of keep a regulated glucose. So that after a meal, our glucose levels tend to rise, but then after a long time, they will start to deplete, and so we're trying to keep it in a nice tight normal range. This is the point. So there are some other cells in there. Delta cells produce somatostatin, which extends the time food is in the stomach, blocks insulin and glucose release. So there is some other types of control, but primarily we're interested in what's going on with beta cells and alpha cells. So insulin and glucagon. So glucagon, we'll start there, produced by alpha cells and these little islands that are found. If we look at, if we look at this picture from before, we can see these little islands. That's how I remember it, called islets of Langerhans. And the islets of Langerhans, or the alpha cells, release glucagon. Okay, with low when blood sugar is low. So maintains blood glucose between meals and during periods of fasting. So it's not that it just magically causes glucose levels to rise. It's going to actually trigger a response in the liver to initiate something called glycogenolysis. Okay, wait, we already covered that term. That's when you break down glycogen. Okay, so glycogenolysis is going to trigger that, which is going to cause glucose to be released. It's also able to stimulate this gluconeogenesis, the genesis of new glucose. So production of new glucose in the liver to build new glucose from amino acids and fatty acids. Okay, so it's increasing glucose, but we kind of want to know exactly how it's doing it. And overall, the release of glucagon is regulated by glucose levels. So, and then I have down here some definitions, sort of. Glycogen to glucose is glycogenolysis. Fat to fatty acids for energy, that's lipolysis. You're breaking down. Lysis means to cut. So you're breaking down fats and releasing fatty acids, and those fatty acids can be used as energy as well. And then amino acids to glucose is gluconeogenesis. All right, so the effects of insulin kind of depends on where it is. Overall, what you're doing, what insulin is going to do. Okay, we know that it reduces glucose, but what insulin does in general is it causes the storage of energy. So it causes, first of all, glucose uptake, and it does that in really all of these tissues, adipose, skeletal, liver. So the uptake of glucose to get it out of the blood. Okay, so that's a prime thing that it does. But then what happens when that glucose moves into these cells? Well, in adipose tissue, it's going to turn it into fat. Okay, so increased triglyceride synthesis. Insulin itself will block the breakdown of fats. Okay, leaving them as triglycerides in general. Okay. In skeletal muscle, uptake of glucose increases glycogen storage. Muscles usually need a quick source of glucose. Increases protein synthesis. Okay, so that makes sense in skeletal muscle, because skeletal muscle has a lot of actin and myosin and other proteins that need to function. In the liver, increases glycogen synthesis. Again, we're making more of those chains. Increases triglyceride synthesis. So we saw that also in adipose tissue, and I mentioned earlier that the liver also can make triglycerides, and then decreases the production of new fats. Okay, or I'm sorry, new glucose. Okay. So in general, if we just sort of think a little bit bigger, besides just, it gets rid of glucose or it increases glucose, and think, okay, but in the cell, though, it has to deal with that, and it has to store energy or make glucose from stored energy. All right. So insulin receptors, this is going to be really important for type 2 diabetes, especially because this process doesn't take place right in type 2 diabetes. So what happens when this insulin is released? And so the insulin will bind to and activate a receptor. So this guy right here is the receptor, and then the insulin binds to it, and that's going to cause all of these things that we just mentioned to happen. But one of the things, so we want the details, okay, it causes glucose to move from the blood. Well, how does it do that? And that's because there's something called a glucose transporter. Now, all this glucose transporter, that's what we see here, all this glucose transporter has to do is kind of exist. It just has to be found in the membrane, and if it's in the membrane, the glucose will move through it, okay? Because it's going to be moving from a higher concentration to a lower. Because as soon as that glucose gets into the cell, it's going to be whisked away, and something's going to be done to it, whether it's turned into glycogen. So as soon as the glucose moves in, something happens to it, and so there's this constant concentration gradient. So all you have to do is get that glucose transporter in the membrane, and then the glucose will move through it for the most part. So that's what happens when the insulin binds the receptor. These glucose transporters are always there on the inside in these little vesicles. So then that vesicle, all it has to do is come up here, fuse with the membrane, and drop off more of these glucose transporters. Okay, and then when glucagon is released, or there is no insulin present, then these will break off again and go back into the cytosol and just be stored. They're just sort of sitting there waiting. Okay, so it's just really a matter of putting them into the membrane, and also, you know, they have to be produced, obviously. So that happens. But really, when insulin binds, it just causes the insertion of these glucose transporters. So glucose is transported across the cell membrane through the GLUT. GLUT4 is what it is. All right. So with diabetes, that means that it's an abnormality in blood glucose, okay? Blood glucose regulation. And that's how we measure it. We kind of monitor glucose levels, and if you're not able to keep your glucose within that tight little normal range, then that can be an indication of a certain type of diabetes that we'll talk about. So abnormality in blood glucose regulation, nutrient storage related to an absolute or relative deficiency of insulin and or a resistance. So we're kind of tiptoeing into these types, type 1 versus type 2. And in type 1, you actually can't produce insulin. Remember those beta cells we were talking about? The beta cells are destroyed. Okay? And since the beta cells make insulin, you really don't have insulin. So we call that an absolute deficiency of insulin. Okay? So why are the beta cells being destroyed? Most of the time, it's because your immune system is destroying them. A T cell response, and they are taking out beta cells specifically. Okay, so there's something on the beta cells that your immune system doesn't like, and so it destroys them. That's type 1. So we call that insulin dependent, because if you're not making insulin, then you have to inject insulin. Okay? You can't eat it because it's a protein and your stomach would break it down, but you have to supplement your insulin. Type 2 is different. That means that the beta cells are perfectly fine. In the beginning, the beta cells are fine, just trying to do their job, but the cells don't respond. Okay, so the cells where insulin is being taken up, the liver cells, the fat cells, the skeletal muscle, where those receptors are, they're not responding. So we call that insulin resistance. So even though you're making insulin in the beginning anyway, even though you're making insulin, the cells aren't responding to it the way they're supposed to be. So same effect, high blood glucose, a relative lack of insulin. Okay, so so over time you can sort of stop producing insulin, but in the beginning it's as though it's really as though the insulin isn't there, but it actually is. It is there in the beginning. So I hope that makes sense. It's confusing because of the way drugs work. In the beginning, you'll see really, really high levels of insulin, and yet your glucose level is still really high. But then as time goes on, those beta cells will actually start to deteriorate, and then your insulin levels will drop as type 2 progresses. Gestational diabetes is associated with pregnancy, and we're going to go through these again. I don't know why I spent so much time on it here. And then diabetes insipidus, we've talked about that. It really isn't, it's not diabetes mellitus, it's really separate. I wish it had a different name, but it doesn't. It's related to antidiuretic hormone. So we've discussed that in another part. Okay, so type 1, destruction of pancreatic beta cells, prevents release of insulin. Type 1A, which is most of them, is autoimmune. Type 1B, we don't know. Okay, we just know that beta cells don't produce, or beta cells are missing. We don't know that it's, we don't know why. That's idiopathic. We're idiots. So type 1, autoimmune destruction, genetic predisposition, which means that you're not guaranteed to get it if your parents had it, but there's an increased chance. that means that there's usually some kind of environmental trigger. It could be like a disease or a virus or something that confuses your immune system, and then it starts attacking beta cells. We don't really know. But either way, there's something that leads to T cell lymphocyte-mediated hypersensitivity reaction. That's a type 4 hypersensitivity because it involves T cells. Inherited HLA, which is essentially your MHC protein or gene. So inherited human leukocyte antigens are strongly associated with the development of type 1. So that's true. Okay, so that particular gene and gene product are associated with it. The more similar they are in parents. All right, so more common in young persons. So type 1 is what they used to call childhood diabetes. It's one that occurs usually in children, but it can occur at any age. And it's an absolute insulin deficiency. So you need insulin replacement, and you're prone to ketoacidosis, which we'll talk about. So type 2, again, to go over this again, characterized by insulin resistance and increased glucose production by the liver. So the pancreas produces insulin, but the insulin has little or no effect. Over time, the beta cells may be damaged, impairing insulin release, possibly requiring insulin injections. So this is where, in the beginning, all you're trying to do is get the cells to respond. That's what metformin medications do, some of them. But then over time, as you stop producing insulin, then you need different medications which will actually stimulate more insulin release and try to get the cells to respond. So medication can be a little tricky as type 2 diabetes progresses. Over 90% of newly diagnosed cases are type 2. So it's more common and generally occurs in older people. They used to call it old age diabetes. When I was a kid, they did. And it was something that people developed later in life. It's that age is getting younger and younger and younger, unfortunately, and it is progressive. So once you've been diagnosed with it, it usually doesn't get better. It can be managed, but it tends to be progressive. So insulin resistance, again, insulin is released but has little or no effect. So what happens is the insulin will still bind to the receptor, but then some of these steps in here do not take place. The step that we're interested in, though, is the insertion of these glucose transporters, and so that may not happen, or that doesn't happen, or it happens at a lower rate, or in some cases the glucose transporters don't function the way that they're supposed to function. But either way, you're not getting that response that you need, which is to get glucose into the cells. So reduced glucose uptake, excessive hepatic glucose production, because the insulin is also one of the things that it's saying is it's telling your cells, especially in the liver, it's telling them to stop making glucose. It's saying we have enough. So insulin is saying, hey cells, we've got a lot of glucose out here in the blood. We need to get rid of that, and you need to stop making more glucose, liver. But the liver doesn't get that message, and so it continues to produce more glucose. So it can kind of snowball, be a big problem. So over time, glucose may actually inhibit the secretion of insulin from beta cells, and which I mentioned earlier is kind of a type of positive reinforcement. So more glucose leads to less insulin, which leads to even more glucose. Okay. All right. So progression of type 2. It's highly associated with obesity. Obesity, and that's something that we can measure, but really it has to do with the way that we eat sugar, or sugar, I guess is the safe way to say that. Glucose, fructose, all of them, and increased sugar, high sugar tends to be correlated with it as well. But we do see obesity as being highly correlated with it. So progression is associated with high fasting plasma glucose. Okay, so that means you don't eat, but yet your glucose levels don't fall the way that they're supposed to. So they just stay in the cell. High BMI, body mass index, weight gain, high plasma insulin, and younger age. Okay. That's so what that means is that if you get type 2 diabetes at a younger age, you're going to see an increased progression. So all of these things are going to lead to increase a quicker progression. So let's see, reduction in hepatic insulin sensitivity is involved. We've already kind of mentioned that. The liver's not responding. Beta cells aren't working the way they're supposed to. Other tissues that have insulin receptors aren't working as well. And then I have here chronic high free fatty acids produced in adipocytes. So this is kind of interesting. What happens in fat cells is that fat cells are when insulin is not present, then what happens is there's something called hormone sensitive lipase activity, and so that will actually increase and will, because of this insensitivity, so the cell being insensitive to the insulin, and so that causes fat cells specifically to increase triglycerides. So it's taking these triglycerides and it's either not forming them properly or it's a lipase. Okay, so it's actually breaking them off, and it's causing these triglycerides to build up, or I'm sorry, fatty acids to build up, and these fatty acids then can move out of the blood, and then they can move to the liver. It's supposed to be a liver. They can move to the liver, and the liver will then put those together as triglycerides and makes cholesterol. Okay, so cholesterol. And so what you see is an increase in fatty acids, you see an increase in triglycerides in the liver, and you have an increase in release of low-density lipoproteins, because the very low-density lipoproteins are carrying these triglycerides, and then they drop some of those off, and it causes the production of low-density lipoproteins, which is the bad cholesterol. Okay. Okay, so that's just kind of one of these little side effects that also happens in type 2 diabetes. So so once type 2 diabetes develops, it's very difficult to reverse it, and somehow I have part of this left. Okay, so once it's developed, it's difficult to reverse. Insulin resistant often improves with weight loss, so that's one of your treatments, weight loss. And then exercise. Exercise is really important because it's directly tied to glucose levels. If your glucose levels are high, if you run up a couple of flights of stairs, that glucose is going to be used up. Okay, so that's another thing that can happen. All right. So metabolic syndrome is kind of related to diabetes, but really what it is that it's a set of conditions that increase your risk of diabetes. Okay, so or cardiovascular disease. Okay, so it's not really just tied to diabetes, but it's a set of here, we'll just read through it. Elevated fasting glucose. Okay, so if somebody comes in and they have high fasting glucose on a regular basis, they have high triglycerides, they have low good cholesterol, low HDLs or high LDLs, elevated blood pressure. Okay, so we can't say elevated blood pressure, oh, you're going to get diabetes, but some of these things together, so at least 3 of these, can tell you pretty solidly that you're going to have an increase. You have an increased risk of diabetes, you have an increased risk of cardiovascular disease. And so even though just having these numbers doesn't necessarily mean that you're sick right now, it means that you have a very high chance of being sick. So so it's something to be concerned about. It's something to do something about. And so it has the name metabolic syndrome, sometimes called syndrome X. And it has all of these, at least 3 of these characteristics. Elevated fasting glucose, increased triglycerides, reduced HDL, high blood pressure, and central obesity, like this guy. So it tends to be central obesity abdominal, because that means that that fat is building up on those internal organs as well. Okay, so increased adipose tissue around the waistline is a big risk for type 2 diabetes. Generally in women over or I'm sorry, not over 35, but over 35 inches in women and over 40 inches in men. So if you were to kind of put a tape measure around there and measure it, that's what we're talking about. It would be under his arm though. Okay, so gestational diabetes. That's when someone is pregnant, a woman is pregnant, and she tends to show some insulin resistance primarily. And it's although it's not really known, it's not known why type 2 diabetes specifically is caused anyway. It's also not known in gestational diabetes, but there is an increased risk a lot of times, and pregnancy can trigger diabetes, and it's called gestational. So women with gestational diabetes are at high risk for complications of pregnancy, mortality, fetal abnormalities, and they're also likely, possibly, going to get diabetes mellitus after delivery. Within 5 to 10 years after delivery, they will go on to actually get type 2 diabetes. The only rule here is that it's first detected during pregnancy, and it has to be detected a little bit later on in the pregnancy. So if it's detected, like the person goes in, then their first checkup, and they check blood glucose levels, and they're high, well, they may have already had type 2 diabetes, or at least pre-diabetes, and they were already developing this. So that wouldn't necessarily be gestational. That would then just be referred to as type 2 diabetes when they started. Okay. All right. So risk factors. So what can lead to this? Family history of diabetes, obesity, glycosuria. So that means glucose in the urine, which really is kind of an indication of pre-diabetes. It means you already have too much glucose. History of stillbirth, spontaneous abortion, fetal anomalies in a previous pregnancy, or a previous large or heavy for date infant. So big babies sometimes just means that that they're it could be from gestational diabetes, or at least could be an indication of that. Advanced maternal age, over 25 years. How's that? 26 years old, you're advanced age. 5 or more pregnancies can also be a risk factor. So ADA, American Diabetes Association, recommends a glucose tolerance test between week 24 and week 28 who have not previously been identified as having glucose intolerance. This is going to include, so most people, I think, would have this test done, the glucose tolerance test. And we'll move on, and we'll start to talk about, because maybe you don't know what a glucose tolerance test is, it's listed here. And so there have to be ways to monitor glucose, and I think these are kind of important, especially fasting blood glucose, the glucose tolerance test, and then glycosylated hemoglobin. This is called the A1, or the HbA1c, the hemoglobin A1c test. So we'll go through all of these, but fasting blood glucose, that just means that you don't eat. So food's withheld for 8 to 12 hours. Remember, after a meal, your glucose levels rise, and then the insulin is and so it may take a little while for it to get into a nice range. And so what you're trying to do is wait to that point where your glucose levels have normalized. And if your glucagon insulin, release is working the way that it should, then you should have a normal level. So less than 100 is usually what the target is. But that's fasting. Casual, you can take it at without regard to meals. It's going to be less accurate because of this heavy change. But you don't want super high glucose levels at any time. Really, you should be able to control it. Now, the glucose tolerance test that we just mentioned, That one's kind of interesting. You provide 70 milligrams of glucose and 300 milliliters of water. So essentially what you're doing is you give somebody sugar water, and of course their glucose levels are going to spike. And then you just kind of wait a couple of hours and see how well their body dealt with it. Okay? And they say, okay, after 2 hours you were here. If your insulin is not working right or you don't have enough insulin, it's going to take longer to get it down. Okay, so then after 2 hours, you're going to see, I don't know, we'll make it at the same place, you're going to see elevated glucose. So if this is normal down here, then after 2 hours, it should be normal. If it's not, if it's still elevated, then you know that there's a problem, okay? And then further testing will be done. All right, so that's the oral glucose tolerance test. With sufficient insulin release, blood glucose levels return to normal within 2 to 3 hours. Higher levels mean that that there's a problem. Now, glycosylated hemoglobin, or the A1C test. That's what we a lot of times hear that called, the A1C test, or the hemoglobin A1C test. What happens with hemoglobin molecules in general, I'll just draw this as a hemoglobin molecule, is that they get glycosylated. That means little sugar molecules will kind of build up on some of these, on this protein. Right? And over time, and that's perfectly normal to happen. It's going through your blood, you have glucose in your blood, and it can stick to the hemoglobin. The thing is that we kind of know how much glucose will stick to this hemoglobin over time. And it really is correlated with how much glucose is in the blood. Okay, so if your blood glucose levels are consistently high, you're going to have more glycosylated hemoglobin. You're going to have more glucose that's kind of growing out of these, not really growing, but stuck to it. And so since red blood cells last, 3 or 4 months, then what happens is the red blood cell that was produced yesterday doesn't have very much glucose on it, okay? Hasn't had much time to build up very much glucose, but those that are, a couple of months old are going to have a bunch, okay? In everybody, or more in everybody. So, but the higher your glucose was over that 3-month period, the more is going to be collected. It's going to collect more rapidly. Even on the younger ones, you're going to have a little bit more. And so you can sort of, what this does essentially, from just plain language, what it does is it can tell you on average over the past 3 or 4 months how much glucose has been in your blood. Okay, so you can't cheat the test is what it is. You can't just not eat the day before or not have any candy bars 2 days before and expect a good A1C reading if you've been kind of splurging during that time. So that's the point of this. That's why it's such a cool test, is because it's measuring an average over time. It's not just taking it one day like the fasting blood glucose level does. Okay. Oh, and then urine tests, urine ketones for type 1 and those prone to ketoacidosis, and we'll talk about ketoacidosis. So categories of risk, these are just numbers here, but generally less than 100 is considered normal for fasting, and then it gives all of the numbers. You don't have to memorize all of those for this class. So diabetes management, anti-diabetic medications. Type 1, you always need insulin. Type 2, you can use, there are many other medications that have slightly different mechanisms. Diet, for type 1, monitor foods so you can adjust your insulin. Type 2, weight loss. Okay, so weight loss is going to be a big help, and diet, and exercise, which is listed here. Type 1, like everyone, general benefits of exercise, but insulin adjustments may be necessary. If you exercise more, you burn more glucose, which means you're going to need less insulin if you're type 1. Type 2, weight loss is a big goal. Enhances peripheral insulin reception and can lead to hypoglycemia, which is kind of an indication that maybe your receptors are starting to work, okay? Now, the important thing is it needs to be regular exercise, not sporadic. If it's sporadic, then that's just going to cause you to get dizzy, lightheaded, and pass out. You want your body to adjust and to get to sort of adapt to having regular exercise. Okay, so complications, diabetic ketoacidosis. Remember, earlier we were talking about how insulin causes storage of fats. Okay, so it causes storage of energy. So it's going to cause one of the things it does is it causes glycogen to be formed, but it also triggers the production of fats. Okay, so that's one of the things that insulin does. And glucagon, however, does the opposite. It causes those fatty acids to break off and then be broken down and used as energy. Okay? When we break down fatty acids, we produce something called ketones, which are a form of energy, and they can be used as energy, but they tend to be acidic. When they build up to really, really high levels. So people on a keto diet or something like that, they can adjust because the body has all these regulatory mechanisms in place. However, with something called diabetic ketoacidosis, the person may lack insulin but still have a high release of glucagon. Okay? And so that's really the trigger, is the glucagon is signaling the breakdown of these fats, and so it's saying it's producing these ketones. And here are some examples of ketones, and you can see that some of them are acidic. So it leads to increased production of ketones by the liver, and that's going to cause a decrease in blood pH, which brings with it a whole other host of problems. So slow onset, prolonged recovery. So the clinical presentation, the way you're going to see that is a couple of days, they've been urinating more, they've been thirsty, there maybe is some nausea, vomiting, fatigue, so maybe these are associated with the blood pH changes, and so that's what they've been experiencing. Now maybe you also may notice fruity breath. Acetone tends to be volatile, or ketones tend to be volatile, and so you can smell that on the breath. And so it'll be a fruity or aromatic kind of a smell that's not typical. There may be some abdominal tenderness, hypotension, and then this would be considered metabolic acidosis, okay, because it's not coming from respiratory, and so and that's because of the production of these keto acids. Okay. Compensatory mechanisms, tachycardia, so increased heart rate, increased breathing. These are just compensatory mechanisms associated with acidic blood. Okay, so you're going to try to blow off some of that carbon dioxide and get rid of it. Okay, so that's what happens with diabetic ketoacidosis, and so just kind of understand this progression and what you see, because you might have to say, okay, well, you notice a client comes in with these symptoms, they're type 1 diabetic, what do you suspect that it might be, kind of thing. Okay, so again, lack of insulin, ketoacidosis mechanism. Lack of insulin leads to the release of amino acids from the muscle fiber. Okay, amino acids are released from the muscle fiber, which get converted to glucose made inside the liver. So we didn't really talk about the amino acids. I keep forgetting about that. Glucose becomes abundant in the bloodstream. Okay, so this is kind of the trigger for glucagon release. So you produce glucose from amino acids, and then the fatty acids and glycerol are released from adipose tissue, which the fatty acids can get converted into ketones inside the liver, and that's going to be your release of the ketones. Okay, which is going to cause the acidosis. So along with fatty acids and glycerol, the glucose produced from the lack of insulin also gets converted into ketones inside the liver. Okay. All right. So summary, I have a summary here. The lack of insulin and production of glucagon forces the cells to produce glucose from alternate sources like glycerol and fatty acids, and the result is numerous acidic ketone bodies. Now, there's something else called hyperglycemic, another complication, hyperglycemic hyperosmotic non-ketotic syndrome. Okay, so hyperglycemic means that your glucose levels are high, and hyperosmotic means that you have a lot of particles in your blood, aka glucose. Okay, so you have increased osmotic potential in your blood, primarily from the increase in glucose in your blood. Okay, so that means that your blood volume is going to rise. So seen most frequently in individuals with type 2 diabetes, insidious, which means that it's slow and not noticed, onset, and high mortality. So it occurs most frequently in elderly, is often mistaken for a stroke because of the neurological manifestations. When you have this increased osmotic potential, it's going to start sucking water out of cells, and neurons are cells. And so this high osmotic potential out here is going to pull that water out, and these cells will shrink, and that's going to interfere with their function. So that's why there are neurologic manifestations. The difference between insulin levels are low, so glucose levels are high, so that's similar to ketoacidosis, but the insulin levels are high enough that it prevents fat breakdown. So remember, the low insulin and the high glucagon before was causing ketoacidosis. But in this case, even though insulin levels are decreased, they're high enough that they're not going to cause ketoacidosis. They're not going to cause the breakdown of fat. And so, really the focus here is really just on this buildup of glucose in the blood, causing a hyperosmotic state and sucking water out of cells. Okay, pretty much. So characterized by hyperglycemia, hyperosmolarity, pulls water from cells, leads to dehydration, excessive thirst, neurological signs, symptoms, seizures, hemiparesis, aphasia, visual disturbances. So it can cause a lot of neurological and symptoms. So absence of ketoacidosis, and that's another thing. That's how you're going to tell. You're going to say, oh, well, the blood pH is fine. This person is having neurologic symptoms, and their blood glucose levels are elevated. Okay, so there could be a decreased level of consciousness. That's what LOC means. So precipitating factors that contribute to the development of hyperglycemia, increased resistance to the effects of insulin. Okay, makes sense. Blood glucose levels higher. Okay, and excessive carbohydrate intake. Okay, and then there is simply an acute complication, hypoglycemia. This is not difficult because we're talking about glucose levels in the blood falling. Okay, so maybe somebody took their insulin in the morning, didn't remember that they took their insulin in the morning, and took it again. Okay, and so that's going to cause a heavy decrease, serious decrease in blood glucose levels, hypoglycemia. Okay, so often referred to as an insulin reaction. Excess insulin in the blood with below normal serum glucose levels occurs most commonly in insulin-dependent people. And that's because of, and here are some precipitating factors, insulin dose error, okay, which is what I just mentioned. They don't eat when they're supposed to eat, but they still take their insulin, and their insulin is trying to get rid of sugar that they didn't put in there. Increased exercise, so they're burning the glucose, but they still take their insulin, and so that's even more of a decrease. So decreased insulin need after removal of stress, medication dose changes, alcohol actually can cause hypoglycemia itself. So drinking alcohol, if you're a type 1 diabetic and you're taking your insulin, drinking alcohol can cause a decrease. Okay, so rapid onset, progression of symptoms, wide variation in signs and symptoms, altered cerebral function, headache, difficulty with making decisions, seizures, behavioral disturbances, coma. I've seen people pass out from this. I remember I was at a bar one time and I saw someone passed out, and it turns out that this was what was happening is she was drinking, but she was, she had also taken her insulin, and so she had an unhealthy drop in glucose. Now, one of the things, so peripheral and sympathetic nervous system effects. So the thing is with someone with hypoglycemia, sometimes when people are type 1 diabetic, we tend to think that's their medication, their cure, and so when they pass out, we might think that they need insulin, but they don't. They need the opposite of insulin. Usually they need sugar. Okay, so they need something to increase their glucose levels. Okay, let's see. There are a couple of things here we're going to mention, some weird things that happen with diabetes. And that is, one of these is called the Somogyi effect, and one's called the Dawn phenomenon. The Somogyi effect, so what happens is something normal, actually, in a way, is that through the night, okay, and it's important that both of these that we see here are increases, high elevated glucose levels in the morning. Both of these are Somogyi effect and the Dawn phenomenon. But what happens is overnight, you have a decrease in glucose, okay? Which makes sense. You're not eating, it's a fasting time. And so, but around 4 a.m., in this chart anyway, around 4 a.m., your body sort of notices and it says, whoa, our blood glucose levels really are low, and so we need to do something about it. So it starts, there are lots of things, remember, that can cause an increase in blood glucose. Epinephrine is one, glucagon, obviously, cortisol, growth hormone, thyroid hormone. So all of these other things can also lead to an increase in glucose, and so the body sort of gets stressed, and then it releases these other factors and causes a spike in blood glucose. Okay, so it's sort of a normal response in a way, but since a person is having trouble controlling glucose levels in general, what happens is that it's not very well controlled, and so you see a spike. So this is over 200, which is very high. Okay, and so that's called the Somogyi effect. The Dawn phenomenon, same thing. You have an increase in blood glucose levels in the morning. It's just that it's not necessarily from this. It's not a rebound effect from hypoglycemia. There may not be any hypoglycemia. It just may be an increase in blood glucose. So that's really the difference between Dawn phenomenon and the Somogyi effect, is that the Dawn phenomenon, we don't really know why or what's causing that rise. Okay. Other complications, and these are big, because this is one of the reasons why diabetes is so bad, because it causes vascular complications. So microvascular means little tiny vessels. Macrovascular means larger, like arteries, things like that, arteries, arterioles. So we have microvascular. We remember that neurons also have a blood supply. Okay, they have to, because they're very dependent on ion concentration. So they have little vessels around them, and they're tiny little vessels supplying them with blood. Okay. The thing about blood glucose levels being consistently high is, remember that glycosylation that happened with hemoglobin? That can also happen to cell surface proteins on blood vessels. So here's a blood vessel. It's got the endothelium, and it's going to have proteins there. And so you can have glycosylation of these proteins, and that can cause, and it's not really completely understood, but it can cause destruction of these cells. And destruction of a very tiny capillary means that, or part of it means that these capillaries can just sort of go away. If you kill the capillaries that are feeding a neuron, that neuron's going to die as well, okay, eventually. So that's why we see microvascular complications and neuropathies, okay, because we're killing off the blood flow to these neurons, then the neurons can't function right at first, and they may die at some point. Nephropathies, remember, we have the glomerulus, which are tiny little capillaries, and those can die in the same way, and so that's going to cause kidney damage. Retinopathy, same thing, small blood vessels in the eye, and can cause blindness. So macrovascular, so these are going to be more associated with cardiovascular and cerebrovascular disease, maybe clots, atherosclerosis kinds of things can be increased in someone with diabetes. Foot ulcers can happen because you've cut off blood supply, and it usually tends to happen more in the extremities where you've cut off blood supply to an extremely where the pressure is really low and it's hard to get the blood there in the first place. So when you block blood supply to those extremities, particularly the feet, then it can cause that tissues to die. So the exact causes are unknown, but there are proposed mechanisms, and one of these is just, we know that it has to do with increased glucose over time. It is the glucose causing it. It's not some other disease or mechanism. Okay, so diabetic neuropathy, so I already went through this, so I'll go through it again quickly, but pathological changes, thickening of the walls of nutrient vessel, the nutrient vessel meaning the thing providing blood to the neuron, that supply the nerve, leading to ischemia, and that's responsible for neural changes. So it's the microvessels supplying the blood to the neurons, not direct damage of the neurons, it's cutting off the blood. So it can cause segmental demyelination of Schwann cells. Clinical manifestations vary with the location of the disease. There's somatic, which is something we can see. So we see that blood is not getting to certain neurons that we can sense. That's somatic. We're aware of it. So diminished perception of vibration, pain, temp usually happens on both sides and is symmetric, often occurs in a stocking glove pattern, which means that stockings are covering the feet. So where socks would cover, where gloves would cover, that tends to be where it's affected first. Increased risk of falling, serious burns, injuries to feet. So those are things that we can sense and see. However, autonomic could be defects in vasomotor responses. So that means that maybe there are neurons that are being damaged that are causing cardiovascular responses or cardiac responses, gastric motility. So we can't really see those, they're not our feet, but you can have decreased neuronal signaling going to those as well. And so that's not going to be a conscious thing, but it's going to have an effect. So impaired gastric motility, hypersecretion, which is diarrhea, inability to empty the bladder, urinary stasis, UTIs, sexual dysfunction. Diabetes is a leading physiologic cause of sexual dysfunction, right? So if we're talking about blood flow, well, blood flow to the penis is one of the things that causes an erection, and so that's going to be inhibited. As an example. So retinopathies, again, leading cause of acquired blindness in the US. So risk factors, yeah, poor glycemic control. You're not controlling your blood glucose, elevated blood pressure, hyperlipidemia, so increased lipids. So all of these things are associated, especially with type 2, but also type 1. Characterized by retinal hemorrhages. So these, again, come back to these small blood vessels. Microaneurysm formation, neovascularization, and associated hemorrhage. So you're destroying blood cells and then you're trying to rebuild new ones, which are not going to be as effective, and they're going to affect your vision. Okay, retinal detachment may happen, but it all really comes down to this microvascular damage. Macrovascular. Diabetes is a major risk factor for coronary artery disease, stroke, peripheral vascular disease. And what we see here is a buildup of plaques and damage to larger vessels, okay, which is going to increase because you have higher triglyceride levels, you have higher LDL a lot of times, depending on how well it's controlled. Diabetes is controlled, and these things can all lead to arterial damage. So multiple risk factors for vascular disease are present in individuals with diabetes. Okay, so it's saying maybe it's not the diabetes, but it's these other things, the obesity, hypertension, hyperglycemia, all of these things are associated with increased macrovascular problems. Hyperlipidemia, altered platelet function, elevated fibrinogen levels, okay, which are going to lead to more clotting. Okay. All right. Diabetic foot ulcers, this is a big one. So distal symmetric neuropathy is a major risk factor for foot ulcers. You tend to not have blood flow to certain areas. So there's already a decrease in blood flow, causes some tissue damage around the area. A lot of people will have toes that will turn black because they can't get a blood supply, okay, due to this vascular damage. So it's tested. So diabetics can be tested, and they put these little threads that bend at a certain pressure, and then you can get a difference in how much can be sensed, and then less sensation is usually an earlier indicator of damage that's taking place, and so that's why it's recommended. Person with diabetes should receive a full foot exam at least once a year, and then they use these to test it. And that's the last slide for this section, this chapter.